Hello, friends. A very good morning, good afternoon, and good evening to all of you who have joined from different parts of the world. I welcome you to this inaugural episode of End Malaria Dialogues, featuring insightful conversations with those contributing towards ending malaria by 2030. These End Malaria Dialogues are co-hosted by CNS and the CSO platform in the Mekong region, which is the first malaria CSO and community network globally funded by the Global Fund Regional Artemisinin Initiative Grant. As we know, governments worldwide have committed to end malaria by 2030 as part of the promises enshrined in the UN Sustainable Development Goals. Malaria not only endangers health, it also perpetuates a cycle of inequity. In 2022, there were 608,000 malaria deaths, 95% of which occurred in Africa alone. Home to 94% of malaria cases, which is 233 million, the African continent carries a disproportionately high share of the global malaria burden. I extend a very warm welcome to our esteemed panelists for today's session, Dr. Michael Adekunle Charles, Sriram Natarajan, Dr. Marijke Wijnroks, Professor Maxine Whitaker, Alois Urasa, and Louis de Gama. Just a few housekeeping announcements before we begin. Participants, please keep yourself muted as the panelists present. Please be free to type your questions and comments in the chat box even as the conversation goes on. We will take them up once all the speakers have presented. Without any further ado, I now invite our first speaker, Sriram Natarajan, co-founder and CEO of Molbio Diagnostics, that has developed point-of-care and people-centered diagnostics for malaria and other diseases. Sriramji, welcome. You were instrumental in developing world's first point-of-care malaria diagnostics about 3 decades back. Also, the WHO recommended point-of-care molecular testing platform developed by your company can diagnose over 40 diseases, including malaria. Please share with us how this has helped advance the fight to end malaria and the way forward to achieve zero malaria cases and deaths. Over to you.
Thank you, Shobhaji. Thanks for the nice introduction. I'm very happy to be part of this panel. So just to give you a brief, I've been in the malaria diagnostics area, both as an innovator as well as a manufacturer for the last 24 years. My first company, Tulip, we launched the RDT for falciparum malaria called Paracheck. At that time, this was the first product to be introduced commercially. And it was a revolutionary product and soon saw a global uptake and also got endorsed by WHO and later pre-qualified by WHO. This product revolutionized the way malaria testing happened because before that, it was the gold standard technology for microscopy that was applied, but it had its own limitations, and the RDT completely solved the problem by making it completely point of care, and where diagnosis could be done practically at any level. And that changed the paradigm for the malaria testing business. And we saw that this uptake has, over a period of time, helped significantly in identifying malaria at early stages in high burden countries and helped in reaching proper treatment to people at the right time. And we are seeing that as the program moves forward, both in terms of prevention, diagnosis, and treatment, the mortality rates in general have come down in the last, say, 20, 25 years of very serious interventions coming from Global Fund and many funding agencies and funding all of malaria testing and treatment. So I'm sorry for the background. I'm sitting in a place that is not able to avoid this.
Yes.
I hope that you're able to hear me well.
Yes, that's fine, Sriramji. Please go ahead. Yes.
Yeah. So as this RDT became popular, the overall magnitude of testing increased significantly. Today, the ecosystem is very large, with many players now with their RDTs in the market. Over 100,000 tests are done using RDTs now, which is a phenomenal number of testing that's going on. So this by itself is contributing significantly. However, we have been seeing that RDTs, while they're very good for high burden countries where the parasite loads are high, do have limitations. So first limitation is when you use the HRP2 as a marker, there are problems with deletion mutations in many countries where the HRP2 doesn't work. So RDTs fail in those kind of places. Also, the RDTs have a limitation in sensitivity. So we are able to see only about, at best, 100 parasite per microgram kind of sensitivity with RDTs, which is okay for high burden countries because normally you expect high parasite loads also in these countries. But as we go towards elimination and in low burden countries, the RDTs sensitivity comes down significantly. So it doesn't pick up many cases because the parasite loads are below the detection limit for RDT. And so it's important to have better tools. So molecular diagnostics has been always, again, a gold standard technology for infectious diseases and known to be the most sensitive tool, where we can reach up to 1 to 2 parasites per microgram kind of sensitivity. And the only problem with molecular diagnostics has always been that it was a centralized model, and so the central laboratories can do the testing. So accessibility to molecular diagnostics was always limited. And that's where Molbio came in the picture, where we started working on trying to see how we can decentralize molecular testing and really make it into a completely point of care solution, which can be deployed even at the community level, where even health workers can be trained to do molecular tests, and where it you don't require power, you don't require infrastructure, and still can do molecular tests like a PCR. So the platform called TrueNat was designed and developed by Molbio. Took us about 15 years to do that. And this was always designed to be a multi-disease platform where we wanted to make sure that at the community level, you can do a lot of tests. And that's what has happened now, as Shobhaji has mentioned. Today on TrueNat, we can do 40 different diseases right at the community level. And this includes tuberculosis, includes HIV, viral load, includes hepatitis, includes malaria, dengue, chikungunya, and so on. So that's the kind of capability that we built into the system. These are robust, portable machines that can be even taken to the field for testing in the field level. And the test of malaria is also becoming some kind of an important tool now, because as I said, in cases of subclinical malaria and in low burden countries and countries going for elimination, you need more sensitive tools than RDT. And now with this TrueNat, you can do a molecular test at the same place where you can also do an RDT. So that's the kind of reach that's happened. So we expect that as we go along, the molecular test will also become an important part of the algorithm. So while RDTs will be the main testing for especially the high burden countries, but even in the high burden countries, just as a confirmatory tool, just to ensure that the deletion mutations are not affecting the test result. And even there, you can have subclinical malaria, which still gets undetected. So molecular test can be a confirmatory tool. So we foresee that as we populate these machines in primary centers through various verticals like the TB program and the HIV program, the same machines can also do malaria. So it enhances the capability at the community level for doing this kind of tests. So these are the innovations that are coming up. And as we go along, there will be also a lot more activity happening. We are looking at innovations that even the RDT sensitivity can be further improved. These are early stage work, but as Molbio, we are fully committed to see that very high quality and complete solutions are being made available to the community level, so that this kind of deadly diseases like malaria can be tackled much more effectively. And the path towards eradication is shortened. And hopefully we will reach a very, very good position by 2030. Yeah, thank you very much.
Thank you very much, Sriramji. And thank you for stressing on the importance of taking the diagnostics and tests to the people who are in need of them. And that is where it becomes very important to diagnose early and then treat them with medicines that work on them. I am now honored to invite Dr. Marijke Wijnroks. I hope I'm pronouncing your name correctly, Marijke, or please correct me. Marijke is head of Strategic Investment and Impact Division, the Global Fund. She is also vice chair of the board of Rollback Malaria Partnership to End Malaria. Welcome back to CNS. We've had you earlier with us today, also. Marijke, funding the fight to end malaria is so critical. Can you please share the role of the Global Fund in this fight against malaria and the need to accelerate responses where progress has stalled or gone slow? And can we hope that countries will be fully funding the end malaria efforts? Any other insights also which you would like to share?
Thank you very much, and apologies. I'm joining from my phone because my sound didn't work on the laptop. Yes. For people who don't know the Global Fund, we are a financing agency. We provide funding to low and middle income countries, over 100, and really focused on HIV, TB, and malaria, and then the health system strengthening that is required to fund those three diseases. We've seen tremendous progress. So the Global Fund is the largest external funder for malaria, and if you look at all the external funding available, it's mostly a Global Fund plus PMI, which is also a significant funder, and then the rest is domestic funding. But for malaria, compared to HIV and to HIV and TB, we see that domestic funding is a way smaller pot, because the countries that have the heaviest burden in malaria are also the ones that usually are the low-income countries, very often challenging operating environment, fragile states, so not countries that can mobilize a lot of domestic resources for the fight against malaria. We have seen the Global Fund was established in 2002, and since 2002, I think especially in the early years, when initially we were able to buy the bed nets at scale and distribute bed nets, so that especially children and pregnant women who are most vulnerable could protect themselves at night. In, I believe, 2005, we had quite a radical shift from chloroquine, which at that stage in many countries was not effective anymore, to ACTs that are now the standard course of treatment. And we really saw in the early years a dramatic decline in new infections and in mortality because of malaria. What we have seen since, I think, approximately 2015, there's probably other people online who have more accurate data, is really plateauing. So we saw a fast decline in new infections and in a number of deaths. And then from 2015, we see that's plateauing and remaining pretty stable. There's a couple of, despite all the investments that collectively we're making, there's a couple of explanations for it. Population growth is one of them. So there's more people in the world now, and especially in countries that are most affected than 10 years ago. So that explains part of it. But it's I think some of the key reasons go deeper. We have funding gaps. We've always had funding gaps, but funding gaps over the last couple of years have become sharper and bigger, and that's partly because we see that new infections are increasing. We know that, so we need more funding just to treat people who have malaria and to prevent an increasing number of people, prevent malaria in an increasing number of people. We see increasing resistance patterns. already in bed nets, we've seen that we have to apply the second generation or the third generation of bed nets, who every time come with increasing costs, some increasing cost, even though we try to really negotiate very hard and do market shaping so that the costs are still remain reasonable. But it also means that then with the same amount of money, you can buy less bed nets, because the bed nets we have to use now because of resistance are more expensive. We're really worried about the increasing resistance against ACTs, which is now our standard treatment. There are still limited cases in the African continent, but in the Western Pacific region, there's really concerning, in the Greater Mekong area, concerning levels of resistance against ACTs, and we don't have a lot of fallback positions. And those drugs that we could use in case resistance developed are much more expensive and not yet widely available in the continent. So that's absolutely something that is a concern, but also will make the fight against malaria more expensive. And we see increasing number of malaria cases in because as a result of climate change. There are more extreme weather events, result cyclones, heavy flooding, heavy rains, and all of these have resulted over the last couple of years, what we've seen in an increasing number of malaria. So we are at and then there's like the introduction of new species of mosquitoes. That's the Anopheles stephensi, that's mostly in urban areas and also bites during the day and when the bed net doesn't protect. So we do have a lot of challenges. So we have more malaria, we have high risk of malaria, we have costlier treatment options and prevention options, and we have less funding. So it's a bit of a perfect storm that we are now very busy discussing with all partners to see how we collectively best address that. I think I stop there for now.
Thank you very much. And we hope that as the days advance, the countries take more ownership of the program, and so that the funding gap is reduced. What do you have to say to that, Marijke, that the country should be spending more from their
Absolutely.
own?
I think those countries that can spend should spend more funding. But as I said in the beginning, malaria burden is very often highest in countries that have very limited capacity to spend a lot of funding. Like very fragile states, very low income countries. So this also will be a journey before countries can invest. But absolutely the countries that do have the means to invest in malaria programs should do that.
Thank you very much. I'm now honored to invite Dr. Michael Adekunle Charles, CEO of Rollback Malaria Partnership to End Malaria. Dr. Charles has an extensive leadership experience in public health, medicine, and international development. Dr. Charles, with 79 months left to end malaria globally, are we on track? Can you please share your insights?
Great, thank you very much. And I'm really looking forward to this conversation. I think it's a good question, are we on track? And if we look left, right, and center, we will see that in many cases, we're not on track, unfortunately. I think Marijke really laid the scene in terms of a lot of the progress we've made between early 2000 and 2015, and some of the challenges we've faced since then. You know, funding is one of them, but not the only challenge. We have issues around climate now, and we see that, you know, with increased amount of climatic events, be it floods, then that is really the perfect breeding ground for our mosquitoes. And we've seen it in Pakistan, where there was a 5-fold increase. We've seen it in Mozambique. We've seen countries that are hit twice, 3, 4 times a year with cyclones. And this obviously, you know, causes displacement, the cyclones, but also causes the perfect ground for mosquitoes. We've seen conflicts, especially on the African continent, that's, you know, prevent people from going to the health facilities, again, you know, increasing the amount of cases that we have. So all this combined is really hindering our efforts, plus the fact that they're resistant, as Marijke rightly said. So what are we doing about it on the African continent, especially? As you know, 94% of the global mortality is on the African continent. So we continue to work with the various countries in terms of ensuring that, number one, malaria is prioritized. And we have the political commitment and political will from our various leaders. And that is why in March of this year, we had the 11 high burden, high impact countries coming together in Yaoundé and declaring together to say we need to recommit ourselves towards the fight against malaria. That means political will, that means country ownership, that means trying to do things differently. So in that sense, I think there's quite a lot of engagement from our countries. As we said, funding is another issue that is stalling our efforts in terms of meeting the malaria targets. So again, we work with the countries to see how additional resources can be committed domestically. So really working with them in terms of looking for domestic resource mobilization, looking for those opportunities at country level to partner with the private sector and with others. We know, however, that countries that have defeated malaria have not done it from a health lens alone. And that's why, as the RBM Partnership to End Malaria, we're really calling on a multi-sectoral approach. So really looking at engaging with the Ministry of Agriculture, for example, infrastructure, Ministry of Education, really bringing them around the table and ensuring that we can collectively defeat this disease. I think a lot of the things we're doing as well is really ensuring that community engagement and community activities are really at the center of defeating malaria. If we look at Rwanda, for example, a country that has made tremendous strides, we'll see that engaging the community is really at the forefront of ensuring that we are able to bend the curve when it comes to malaria. Innovation is something else that we're all looking forward to, and we all continue to promote. And again, we have innovation in terms of the dual AI nets, active ingredient nets. We have innovation in terms of the vaccines that are being rolled out in many, many countries today. But again, in the complexities of the vaccines, we also need to state that vaccine is not a silver bullet. We need to continue to use it amongst the many other tools that we have. So are we stalling? I think the answer is yes, and definitely we're not meeting our targets. And as Marijke said, funding is part of that. So what we're doing with countries is to engage them in what we call subnational tailoring. Obviously, when we're looking at the approach in terms of malaria prevention, we see that not one size fits all. Just because we're in a geographical space in the country doesn't mean that the same intervention is used in every single district or in every single region. So really working with countries to try to prioritize in terms of limited resources, which interventions are most impactful where. So that's a process that we will continue to encourage, with WHO obviously leading on this, but really bringing the partners together to see how we work on that together. I think not all hope is lost. Obviously, there has been some great strides. We have the example of Cabo Verde, which was certified malaria-free in January by WHO. That gives us confidence that indeed, we can hit our targets. But collectively, we're not hitting it. Collectively, we're not there yet. And that's why we think, we need another piece of work in terms of really ensuring that countries can come together. So Yaoundé Declaration is a step in the right direction, but we definitely need to bring other countries on board in terms of just making sure that the political level we're there, in terms of maximizing and optimizing funding we're there, in terms of innovation we're there, and in terms of ensuring that communities are engaged in the fight. At the end of the day, it's a collective effort, it's a multi-sectoral effort, and I believe if we all come together, we will be able to we will be able to bend the curve when it comes to defeating malaria. I'll stop here.
Thank you very much, Charles. And thank you for mentioning that we need a basket of interventions. Basically, one size does not fit all. And of course, waiting for also better vaccines to come. We do have the vaccines, but always we need improvement in that. And let us hope we soon get more vaccines, better vaccines, just not for children, but adults as well. And yes, we have to carry on the fight, definitely. Now, carrying the conversation forward, I invite Professor Maxine Whitaker, Director of WHO Collaborating Center for Vector-Borne and Neglected Tropical Diseases and Community Representative at the Global Fund Regional Artemisinin Resistance Initiative. Maxine, although 95% of malaria cases and deaths are in Africa, but there are areas in the Asia-Pacific region as well where malaria has posed serious challenges, including drug-resistant malaria in the greater Mekong sub-region. Please share how far we have come in achieving zero malaria cases and deaths in this region and the way forward. Over to you.
Thank you very much. It's my pleasure to be here from representing the Greater Mekong sub-region. I'm one of the two elected civil society platform representatives to the global funded Regional Artemisinin Initiative grant that's been going since 2013. So far, the Global Fund has spent, until the end of RIFE4, which we're in now, till 2026, from 2014, there has been over $700 million spent in the region. Firstly, that was started to try to address the emergence of artemisinin resistance, first in Cambodia, Thailand, and then seen to spread across the Greater Mekong. The good news is that although there still is some resistance found through the efficacy studies, etc., that are done regularly in the region, artemisinin is still working as a combination therapy, and we need that to happen. Achieving elimination in the 5 Greater Mekong countries is critical, is one of those packages of countries that's needed to reach both the global technical strategy for malaria's goal of eliminating malaria in at least 35 countries by 2030, and one of the SDG indicators. So things have been going fairly well. So fortunately, Marijke, we're not plateauing. That's not the pattern mainly in the Greater Mekong region. From 2013 to 2023, there's been a 67% reduction in overall cases of P. falciparum and mixed cases. There has been a major reduction in any deaths from malaria. 92% decrease to only 15 recorded in 2022 and 2023. And now in the countries Cambodia, Vietnam, and Laos, there are only 2,550 cases reported at the end of last year. Just as an example, in Vietnam now, there's only 2 districts, 3 villages in those 2 districts that now have malaria. So we have been able to shrink that map. The curve has bent in at least those 3 countries. However, these gains are quite fragile. The internal displacement and movement of people across the Myanmar-Thai border has actually created problems not only for Myanmar, which last year recorded more than 210,000 cases, but also Thailand, which was quite close to elimination, last year recorded more than 16,000 cases. So this fragility of the gains made is an important thing to think about, and other speakers have already talked about some of those drivers. And we are starting to see small outbreaks occurring in some locations like Vietnam, able to be addressed, but still, again, that prevention of re-establishment is something that we really need to focus on. as the prevalence has gone down, it's now very much concentrated in more remote areas, marginalized populations, amongst mobile and migrant populations, and a lot of ethnic populations. Most of these people are involved in forest-related work, and as the economic crisis is hitting everybody, we're seeing more and more going into the forests. And so we need to actually try to find ways, innovative ways, to reach these communities. That's where the recognition, the best practices, which you asked me to talk about, I think firstly it was in this WHA grant, recognising and supporting the role of civil societies. Instead of, which was in the first 3 years, the civil society work being very vertical amongst a range of agencies. The Global Fund grant has actually funded the civil society platform, as our chair mentioned, which is the first globally funded or global funded malaria community and CSO network globally. We now have more than 60 CSOs and NGOs that work in malaria in the Greater Mekong, who are coordinated, learning from each other, sharing results, sharing innovations with each other, but also being really important support to the national malaria programs and to the partners who are working with the countries to eliminate malaria. Part of this is also those community-based malaria workers and volunteers. In the 5 countries now, we have more than 34,000 volunteer malaria workers or malaria post workers, plantation malaria workers, and all of these are providing services direct to the community. In some countries, providing almost 100% of the case finding and management of malaria. You mentioned earlier too that need to tailor to local contexts, and this gets more and more important as you start having smaller foci in very difficult, but also very culturally, socially, otherwise different communities. And so you really need to find ways to support services to those people. And that's meant that there's been a lot of innovation required, innovation that's been supported by some of the research partners in the region, as well as outside the region, but working in the region. A lot of the work from WHO trying to think about how to modify strategies, often ahead of what WHO mainstream might be thinking about because of high burden countries, but we need in the Greater Mekong to eliminate, so that's off the agenda, can leave more of the resources available for high burden countries. And also if we eliminate falciparum malaria, we're not going to have Artemisinin resistant falciparum malaria coming from the region because there's no malaria. I think the other thing, as I said, we maintain looking at the efficacy of the treatments. The 5 countries supported by WHO and partners within the region are always doing molecular studies, therapeutic efficacy studies, integrated drug efficacy studies to make sure that the drug treatment protocols are up to date and they are regularly reviewed by the countries. What do we need to do? As I said, we need these 5 countries to reach elimination, but we've got the uptick that's happened with the Thailand-Myanmar situation. As we've already heard, that political commitment is really important, but not only at national level and the sectors working at national level, but also in the decentralized level. There's increasing roles for local municipalities, local governments to have to also be partners in this. And although there's a lot of rhetoric from some of the countries about being committed, it's not being translated into some of the plans or funding that we need to see in the region. Community commitment is really important. We need to support efforts that keep the community engaged, interested, whilst malaria is becoming a rarer thing, and things like dengue, as well as other primary healthcare issues for these neglected populations are a problem. So we need to involve them. We really need that planning, transition and sustainability planning to really accelerate in these, particularly Cambodia, Laos, and Vietnam, and parts of Thailand that are so close to elimination. That needs to be accelerated. But despite that, although many of these countries are quite wealthy now, they're middle-income countries, there are still those really wide inequities in the distribution of wealth. And so somehow we need to think about how do we still address the needs of forest goers, of these ethnic populations, these neglected populations, mobile and migrant populations. The really tailoring, really now listening and working with the communities from co-design through to monitoring and evaluation, as well as implementation, and be better segmented not only in our approach, but in our social and behavioural change communication, as well as taking into account languages, ethnicity, health literacy in doing that work. Meeting the needs of gender equity, social inclusiveness and disability in that work. As we heard from our first speaker, really, we need to fast track that innovation for the last kilometre. We need those tools now because we have subclinical, very low parasite levels. RDTs are not playing the role we need. And we need to ensure that we use the strengths and proven effectiveness of village-based workers in areas like community-based surveillance for epidemic preparedness, go beyond malaria. They proved that they could do that in COVID-19. We need now to build that further. It's a great investment that's been made, and the community want those workers to do more. And we need to monitor to prevent that re-establishment and look at areas also like surveillance by these local workers and community members around land use changes, climate changes, things that are really affecting the ecosystems in which they live, having them engaged in that surveillance and health promotion around those issues, as well as taking a One Health approach.
Thank you very much, Maxine, and thanks for pointing out the crucial importance of the role of community to control malaria as well as any other disease. Without community participation, definitely we will not be able to at least walk that last mile. And also, thank you for pointing out that political will should be matched with action on the ground at local level. And because that is where the problem lies most. So national action is all right, but action on the ground at local level is very, very important. Thank you very much. Youth voices are so very critical in our efforts to achieve the Sustainable Development Goals, including ending malaria. We have with us today Alois Urasa, Chairperson of African Leaders Malaria Alliance Youth Advisory Council, to help us understand the youth perspective on what more needs to happen to end malaria in the next 78-79 months, especially across Africa. Over to you, Alois.
Thank you very much, Shobha. Excuse me for the background noises. I hope you can hear me clearly.
Yes, we can hear you very clearly. Yes.
Yes, thank you very much, and thanks to CNS for hosting this dialogue, which is very timely and very important. That comes after the release of key reports. Last year, we had the release of the World Malaria Report by WHO that really gave us a picture of the perfect storm that Dr. Michael and Marijke have really explained it well in terms of what are the reasons that are making us to making the progress against malaria stalling. One of them, climate change, of course, that as Dr. Mike has explained very well, issues with funding on financing, as Marijke has explained well, issues with conflicts and displacement of people, issues with resistance, biological threats. All this combined with many other challenges that we have been facing, including the behavioral behavioral and structural challenges at community and country levels. All these are really making the fight against malaria, or the progress that has been made before, really sterling. When it comes to youth engagement, now it's not more of coming up with totally new approaches, but a complementary approach to the existing. We look also at the current Commonwealth Malaria Report that shows it's only 4 countries across the Commonwealth countries that have been able to be really on track to meet the targets for the reduction of case incidences, while it's only 5 countries that are on track with the targets of reducing mortality rate across the Commonwealth countries. And if you look at all these countries, it's only 3 countries that are really on track between meeting the targets of reducing both incidences and mortality rate. And overall, if we see that the whole of Commonwealth countries, we are totally not on track to meet the targets for 2030. But now, what is the youth perspective? One is we look at young people as people who brings in the vibrance and the energy to advocate for increased investments in the fight against malaria, and considering malaria as a pathfinder to pandemic preparedness, which really, based on the lessons we have from COVID-19, but also young people are bringing up their voices to bring up malaria as an agenda, that fighting malaria is also a pathway to responding to health threats due to climate change. Because as we fight malaria, we are also addressing the issues with strengthening health systems, building resilient health systems, building a sustainable team of healthcare community health workers that will help not only to support the fight against malaria, but beyond malaria and support the fight against other diseases. But young people are also coming up with innovative ideas in terms of monitoring, surveillance, and case management systems, supporting different institutions. Like if you go to Ifakara Health Institute, you'll find a lot of young scientists coming up with this mathematical modeling, statistical modeling techniques, and a lot of different techniques to support the fight against malaria. But when we look also at the Malaria Youth Champions or Malaria Youth Corps that we are supporting at African Leaders Malaria Alliance in over 45 countries now, but 8 countries official launch, you find young people coming with a lot of different movements to support innovation, but also encouraging young people to bring the malaria agenda high on the table. Another area is multi-sectoral collaboration. We are encouraging the young generation to consider the fight against malaria as not solely a fight for a fight of the health community alone. That's why you'll find in the Malaria Youth Champions, we have a diverse skills of young people, from technology, from computer sciences, from engineering, from agricultural sector. Different young people, just the passion is what makes them become the champions. And we are demonstrating this example also to our leaders, that fighting malaria, you don't need to be in the health field in order to address the issue of malaria, because it's a problem that we are all facing. But again, we are looking at promoting the integrated vector control approaches, promoting local manufacturing to ensure that the most affected countries with malaria can also afford or can be able to produce commodities that are more affordable and more available within the context of their countries. Yeah, just to wrap up, that young people are really becoming great champions, and we see that despite that we are not on track to achieve the targets by 2030, by engaging the young people, we are creating a next generation of leaders, public health leaders, who understand critically what is really taking us behind, what is really making us stop where we are, and what we should do in order to move forward. So we hope with the meaningful engagement of young people, we are going to speed up the fight. And if we don't meet the targets on 2030, then at least we are not going to delay further in the next maybe 15 years to come, or the next global development goals that will be enacted by 2030. Thank you.
Thank you very much, Alois. And we have great faith in youth power. So with the wisdom of the seniors and the energy of the youth, I'm sure we will win this fight. Thank you very much.
Absolutely. Thank you very much.
And last but definitely not the least, we have Louis Tagama, board member at Unit 8 and an outspoken malaria advocate focusing on community empowerment. And Louis will please let us know if malaria responses are people-centered. Are we listening to the people and communities whom we claim to serve? And are we prioritizing those most at risk of malaria, reaching out to them with equity and best of whole cascade of services? What needs to change if we are to end malaria? Over to you,
Bobby, I'm
Louis.
just going to talk a little bit about malaria elimination in terms of communities and community engagement. And if we want malaria elimination efforts to succeed, we absolutely have to focus on communities and remain people-centered. When we speak about communities in the singular, we're not doing them any favors because they're not homogeneous. We must learn to work with communities in all their diversity, with the corresponding challenges, including those that relate to ethnic minorities, internally displaced populations, mobile migrants, refugees, indigenous populations, people living in conflict areas, geographically remote populations, the list goes on. And the clarion call of leave no one behind must be more than our ritual mantra, but it must be transformed into practical and pragmatic action. A bottom-up, inclusive, determined engagement of all communities so that the elimination agenda can be owned and led by them. A differentiated approach depending on their specific circumstances and conditions is essential, as well as an integrated delivery system that manages fevers in children and focuses on the needs of pregnant women will be essential. When communities are faced with current problems like dengue, and it's not being included in the package of services delivered by community health workers and volunteers, we are missing a real opportunity that reduces the trust and the impact of community health workers. If they come to a community health worker and they've taken, the family have taken time to come there and a test is done and the person is, or the baby is malaria negative, and the community health worker is unable to do anything else and sends the patient home without any other medication and without any understanding of what else is causing the fever, we will lose trust. And that goes back to the need for ownership on these issues. At a time when the funding gap to meet all the global needs for prevention, diagnosis, and treatment is over $1 billion short, it is easy for us to focus on commodities that are required to maintain coverage, but that doesn't work. Not adequately funding community engagement and ownership can only result in suboptimal use and therefore failure in terms of impact. With climate change, insecurity caused by conflicts, insecticide and drug resistance, not to mention the new vector causing challenges in urban settings in East and Southern Africa, it is easy to understand why the focus remains on technical solutions. But without the buy-in of the very communities we want to serve, we will not succeed. The Global Fund, the Office of the Inspector General, has already highlighted the poor usage of long-lasting insecticide-treated nets. In their work that they've done in evaluating programs in Malawi, there was only a 37% usage of all the nets that were distributed. In Ethiopia, it was 44%. In Cote d'Ivoire, only 52%, and in Uganda, 58%. Nets distributed but not used, or used inappropriately, result in poor performance. And the impact, not to mention a complete waste of resources. Imagine the billions that are spent on actually procuring long-lasting nets that don't ever get used. Would that not be better for us to actually spend less on buying the nets and spend as much time and effort in ensuring that communities understand why they are being given nets and how to use them? The additional complexity of introducing 2 new malaria vaccines, RTSS and R21, at a time when vaccine hesitancy is at an all-time high, is exactly an additional challenge. And without effective, meaningful dialogue with communities and their leaders, it will be impossible to actually reach the coverage for vaccines. Adequately funding to ensure effective engagement, demand creation, and ownership is truly vital for success. Finally, ensuring communities are also adequately resourced, trained, and mentored to undertake community-led monitoring and community-based surveillance is also critical. In conclusion, our failure to adequately support effective, inclusive community engagement will only result in inadequate impact, poor results, wasted resources. And ending malaria by 2030 will not be possible. It can only be achieved when communities are truly at the front and the center of our response, and that they are adequately funded to make this happen. Thank you very much.
Thank you very much, Louis. And we now open for questions and comments from the audience. We have many questions already. There is a question from Lena Korn from Cambodia. The question is for Marijke. Lena wants to know what will be the funding direction of Global Fund in the next 3 years in low and middle income countries. Is Marijke there?
Sorry, I was
Yes,
at chat and then I couldn't find my mute button.
Yes.
Don't know yet. And we are preparing for the next replenishment in a funding environment that's very complicated. There are a number of organizations need funding. Their donor budget are under stress because also the funding is shifting more towards climate change, away from global health. And their domestic budgets are under stress too, as a number of participants have mentioned. So we don't know. It's going to be, we're going to do whatever we can to have a good replenishment outcome, but it will require the entire community and the malaria community in this case to really support and advocate for funding to the Global Fund so that we can continue, because as I explained and others also talked about, the cost of doing business has increased and the funding is flatlining, so we definitely need more funding.
Thank you. I think there is another question for Marijke. We will come to that. Manjari Pereira from Sri Lanka says drug-resistant malaria is so shocking to learn about today. Is it spreading to other areas outside of Mekong region? And also, is malaria high up on the agenda at the WHO World Health Assembly going on right now? Charles, would you like to answer that question?
Yes, sorry, I was trying to unmute as well. Indeed, the resistance we're also seeing on the African continent, as well as the new vector, Stephen's Eye, that has now come to the African continent. So it's obviously a cause for concern for all of us. And that's where we're saying we need to intensify our efforts. We need to be agile. We need to move fast when it comes to malaria elimination, and we need to do it together. And also learn from the experience of Asia Pacific as well. In terms of WHO and whether it's on the agenda in WHO in the World Health Assembly, certainly yes. As you know, within the World Health Assembly, there are many bilateral conversations as well. I've had about 3 or 4 conversations since it started, where we brought partners together to ensure that We're continuing to keep malaria high on the agenda, speaking to ministers, speaking to the private sector as well, and just making sure that we're all on the same page when it comes to malaria elimination and where we are at the moment. So indeed, it is quite high, and we will continue to prioritize this as much as possible. Thank you.
Thank you. Question from Jitima Janakadamalla from Thailand. I think Maxine has partly answered that question, but Maxine, it would be good if you would please say it out loud for everyone. There are other platforms on which this is being live casted. Why is resistance happening against malaria medicines? Is it because of misuse or irrational use? And do we have new lines of medicines? And Maxine and Charles, this brings to my mind another question, that antimicrobial resistance perhaps is one area where we have to look into it deeply, and that is one of the reasons for the drug-resistant malaria being there.
Yeah, thank you. Thank you very
Yes.
much for the question. Whoops. It's a very important question to ask, and what I noted in the chat was
Yes.
it is very complicated. There are many causes of drug resistance. Eventually, any anti-infection medicine will have resistance developed to it over a longer period of time than we've seen for antimalarials, because the parasites or the bacteria that survive the treatment are the ones that go on to reproduce, and they may carry a gene that helps with that resistance. So that's it. It will occur anyway. What we found with the antimalarials is it happens a lot quicker than naturally it would occur. So some of the things that cause that are people not finishing a complete course. Again, that can be for many reasons. If they have to pay, if it's expensive, they may not buy the complete course. They may share it with others in the family who are unwell. They may have side effects and so don't want to continue to use it, and there's not someone supporting them to understand why they need to use. May take too many days, like the treatment for Plasmodium vivax, and it's hard to keep taking the medicine for that long. But there's also counterfeit medicines that are being distributed globally, particularly a lot of African countries have been facing a counterfeit medicine problem where there isn't the complete dose. There's a little bit of the medicine, but not a lot. And so again, it drives resistance because it allows the parasites that survive to then thrive and be carried to others. And then it spreads because we're very globalized, we're very mobile. And there's some routes we've seen where it's spread in the past when we had chloroquine resistance and other resistances. There's not, at the moment, for falciparum malaria, what is happening is looking at different combinations with the artemisinin. There's some different formulations that are happening. And as I said, in the Greater Mekong, although there still is some resistance to the artemisinin part of the combination therapy, the other drugs that are going in are allowing the combination therapy to still do its job, but it needs careful monitoring. And we do need innovation to try to find others, but eliminating in the Greater Mekong and in areas where resistance has been found will also stop the spread, because if there's no malaria, there's no resistant malaria.
Thank you. Thank you. There's a question for Marijke from CSO platform, that how does the Global Fund plan to continue supporting countries, those soon transiting from the Global Fund grant because of disease burden and income, but yet having risk of resurgence of malaria because of large number of mobile migrant and displaced populations?
I think there will be very few countries in that bucket. The Global Fund only, so all countries that are upper middle income countries with severe disease burden are still eligible to the Global Fund. I don't think there's any malaria country in that bucket. And so I don't think it's more a theoretical question, because I don't think we have transitioned any malaria country out the Global Fund.
Okay. Thank you. Zafar Irshad wants to know that are malaria programs integrated with other health programs that are relevant for migrant mobile populations or those who are at higher risk of malaria? Charles and Alois, would you like to answer that?
Yeah, thanks very much. As much as possible, what we're trying to move away from is having a siloed approach when it comes to, malaria prevention. So even in migrant populations as well, as much as possible, the idea is to integrate it into existing health initiatives. So really looking at health as a holistic, because yes, a migrant might have malaria, but he or she might also have diarrheal diseases and other things. So really looking at it from a comprehensive aspect is what we're always trying to encourage as much as possible.
Thank you. Alois, what about youth groups? Is there collaboration between youth groups who are working for different diseases or in different areas of health? Are you there, Alois? All right, we move on to the next question. There's a question from Shakuntala Joshi that are molecular testing point of care platforms being deployed to test for malaria along with other diseases? Charles, would you like to answer that? The point of care malaria tests, are we using them? I think you are muted. Yes.
My other colleagues to come in on that.
Yes.
Marijke?
Sorry, I missed the question.
Are the molecular point of care testing platforms being deployed to test for malaria along with other diseases?
I don't know whether that is, so at least the molecular diagnostic platforms that we provide are available for all diseases that countries want to use them for. So we don't restrict it to TB.
Okay, yes. And what are those platforms? Just for the sake of our listeners,
I think everyone will remember the PCR test during the COVID, and it's basically you can put in different cartridges that you have to buy separately, and they can test for different diseases. So we bought them in big numbers for TB, but then countries use them for COVID too.
Okay. Thank you very much. I think we have already overshot our time, and we've really had a very good discussion, very vibrant discussion, lot of new learnings for all of us. And my sincere thanks to our wonderful speakers and to our attentive audience for making this inaugural episode of End Malaria Dialogues so enriching and informative with all their inputs. Bye till we meet again for the next episode in this series. Thank you.
Thank you very much.